Winter viruses are here: the flu, COVID-19, RSV. But did you know there are others that can also lead to severe illness or worse? These viruses are highly contagious and can have life-threatening complications, especially for kids, seniors, and the immunocompromised. So how can you protect yourself? Which vaccines do you really need? And what's the truth about preventing severe infection? Our expert panel breaks it down next on viruses and vaccines, breaking the chain of infection. The answers you need, the facts you can trust. Next.
Thank you to the Eunice Joyce Gardiner Charitable Foundation for its leadership support of the Health Channel.
Welcome to Viruses and Vaccines, Breaking the Chain of Infection Town Hall. I'm Olga Villaverde. Respiratory viruses like the flu, COVID-19, RSV can occur anytime, but they usually start appearing in the late fall and they spread throughout the winter. This video explains why. Take a look.
It is true that people are more likely to get sick in the winter.
Most people think that it's just due to more people being indoors, which I think plays some role in it.
Dr. Matthew Binnicker says another factor is humidity.
In the warmer months, there's more humidity. And when we speak, when we cough, when we sneeze, the larger amounts of moisture in the air causes whatever droplets we release from a cough, sneeze, or talking to be bigger. Those droplets are larger in size and they fall to the ground, they fall to the floor faster.
But in the winter, when the air is drier, those droplets that may contain a virus can hang in the air for longer periods of time.
And they can spread further.
It also turns out that a person's immunity is not functioning as well in the winter months.
Cilia, which are these small hair-like projections that usually are moving foreign objects out of our nose. And those cilia don't function as well during cooler temperatures and lower humidity. So a virus is able to kind of persist in our upper respiratory tract for longer periods of time.
For the Mayo Clinic News Network, I'm Dee Dee Stephen.
So there are a lot of viruses out there, and we're going to discuss many of them in this program. But first, I'd like to introduce our panel. Dr. Carlos Del Rio is a distinguished professor of medicine in infectious diseases and chair of the Department of Medicine at Emory University School of Medicine. Welcome, Dr. Del Rio.
Happy to be with you, Olga.
Thank you, sir. Dr. Nicholas Turner. He is an infectious disease specialist at Duke Health and an assistant professor at Duke University School of Medicine. Dr. Turner, again, thank you for being here as well.
Thank you. Happy to be here.
So, gentlemen, let's get started. Dr. Turner, I'm actually going to start with you. Got a viewer question right before we started this show, and I think it's something that a lot of people are wondering as well. Ted asks, can you get more than one virus at a time? Can you chime in on that, doctor?
Sure. Unfortunately, yes. There are over 200 different respiratory viruses out there, and actually when multiple are circulating at the same time, it's fairly common for us to see people test positive for more than one at once.
So, Dr. Del Rio, let me bring you in. If a child or an adult is infected with more than one virus, do you treat them separately, or are there combination drugs you can prescribe?
The problem is, Olga, respiratory viruses, we really don't have good drugs available. For a lot of them, it continues to be pretty much and management of symptoms. There are a few viruses, influenza A and B, that we have some good drugs. For SARS-CoV, for COVID-19, we have some drugs that are effective. For RSV, in children, we have some drugs, but really very little we can do otherwise. So, and a lot of these viruses, we don't have a lot of treatments, and that's why prevention is important, because many times if you get infected, you're not going to be able to do anything. And one example of that is RSV. We have a vaccine. If you don't take the vaccine and you get RSV, there may not be a lot we can do if you're an adult, for example.
Thank you, Doctor. And we're going to talk about RSV in just a little while. But a virus that's been in the news lately is bird flu, or H5N1. This is not a new virus, but it seems to be increasing. California declared a state of emergency because of an outbreak among the state's dairy cattle. And since severe infections have been reported in humans, other states are now on alert. So we're going to talk to the panel specifically about bird flu after we take a look at this video. Take a look.
Bird flu is spread when a human comes into close contact with an infected animal. The virus isn't new, but until lately it hasn't been a big concern in the U.S.
Right now there's a low risk because it's mainly seen in birds, but there's been some rare cases, so we need to remain vigilant. So it is in the community, but still at a lower risk.
Most cases so far have involved farm workers or those in close contact with farm animals. Bird flu can be deadly. In roughly 50% of known cases, the person has died. If it's detected early, the virus is treatable, but people with certain conditions should be wary.
People that have immunocompromising conditions or are pregnant, the elderly, may have some type of chronic conditions such as the heart, diabetes, and especially younger infants that have not developed their immunity may be at risk for more severe illness with any type of influenza, including the bird flu.
While there is no vaccine for the bird flu yet, there is a test to see if you've been infected. So if you think you might be infected, it's important to see your doctor right away.
So, Dr. Del Rio, we're seeing this virus spread through not only cattle, but also poultry. And while the CDC says the virus poses a low risk to the public, we know it can spread from animals to humans. And there are some cases with no known source of infection. So here's a couple of questions for you, Doctor. Should we be worried? And what about human to human transmission?
Well, Olga, always pandemic influenza is something that we're always worried about. And H5N1 is a virus that we've been worried for a long time, since the 1960s. But in general, this virus has remained in birds. Usually this time around, first of all, is that we started seeing this virus last year. In fact, for example, a lot of mammals, let's say in the southern hemisphere. And this year we started seeing them in cows in the United States. We had never seen this virus infect cows. And the most recent outbreak we're seeing is actually there's been cats that have died, and those cats have actually drank unpasteurized milk. So unpasteurized milk infected with the virus. And so the first big message for people is do not drink unpasteurized milk. That is an absolute, no-no, but especially right now with bird flu present in cattle. Now, humans rarely get infected, and the main reason for that is because the virus has not really adapted well to infecting the respiratory tract of humans. And we have not yet seen human-to-human transmission. But the virus only needs to mutate a few more mutations in order to be adapted to infect the respiratory tract of humans. And once it does that, and we start seeing human-to-human transmission, we could potentially have another pandemic, an influenza pandemic similar to what we had in 2009 when we had a swine flu, a bird and pork influenza virus recombined and produce a virus that was capable of infecting humans. The problem with this virus is none of us have immunity against the H5N1 virus. So in fact, the challenge is that while the cases we've seen thus far have been in people primarily exposed to birds or exposed to cattle, people that work in ranches working with infected cattle, many of them had just had symptoms in their eyes, but we are beginning to see cases of severe infection. And this virus, typically when it has infected humans, it has produced a very high mortality. So yes, we're all very concerned. And if there starts being human-to-human transmission, I would be very, very worried. So how worried am I right now? At this point in time, I would say my level of awareness is getting around 6 or 7, is beginning to rise. I'm not at 10 yet, but I'm following this very, very closely. And if we start seeing more human-to-human transmission, I'll get very concerned.
Dr. Turner, what about you? How concerned are you on a scale of 1 to 10 and your thoughts on the bird flu?
Yeah, I think I agree entirely with Dr. Del Rio about where his worry is at. Even though human-to-human cases have not been reported yet, it's noteworthy that these viruses mutate over time, and flu does so in a unique way. It's not just making little mistakes when it copies itself. A big key is that its genetic material is actually in 8 little segments or pieces. And you can imagine that's kind of like shuffling cards if you have 8 separate pieces. You couple this with exactly the issue that Dr. Del Rio was mentioning, a wide variety of different animal hosts that these viruses can infect. And what I just answered earlier, that you can be infected with more different viruses with a single infection. And that's really where the concern is. It doesn't take much for an animal or a human to be infected with 2 different flu strains, allow them to kind of shuffle some of their genes, and you can have much more sudden and unpredictable genetic shifts than you can with a lot of other viruses. And so that's why flu can sometimes move in quick and surprising.
And Dr. Del Rio,
Olga, following what
go ahead.
Turner said, and I like the idea of the cards, the mixes the cards, it's called a pig. If a pig gets infected, that's where the virus recombine. That's where this change can happen. And I'd be very concerned when we start seeing, swine infected. That would be really concerning to me.
And Dr. Del Rio, in that video, they said obviously there's no vaccine for the bird flu yet. How difficult will it be to get one?
Well, there is some vaccine. There's some vaccine that has been produced. We don't know how good the vaccine is because when ago before the virus is where it is right now. But with the new technology we have with our mRNA technologies, hopefully we can produce a vaccine fairly quickly. But I remember, quickly means a year. Quickly means, it's not immediate. So I would be very concerned. And I think a lot of questions right now happening at the NIH and the government level is, do we produce vaccine now? Do we wait? What do we do? We're also testing antivirals against this virus because I repeat, if you get infected, this is not a virus you would not start treatment right now. So far, this virus appears to be sensitive to the drugs we have available to treat influenza. The virus appears to be capable of being killed by the drugs we have available, but we may not have enough of those drugs, so we need to start producing more of those drugs. So again, right now, it's almost like getting ready for a forest fire. Nothing has happened yet, but you need to start getting your ducks in a row. You need to start being sure that you have the things necessary in order, should this start spreading, you don't start from zero. You start really from having a lot of things already thought.
And Dr. Del Rio, let me follow up again. You and obviously the CDC has recommended against consuming raw milk. Are there other types of foods parents should be concerned about? And just tell me the concerns with the raw milk.
No, the concern with raw milk is that the virus survives in raw milk. It's present. The cows get infected. The cows get infected in their mammary glands. So the virus is highly concentrated in milk. The process of pasteurization kills the virus. But drinking raw milk, to me, is the most dangerous things you can do if you're concerned about H5N1. At this moment, I never would recommend drinking raw milk. There's a lot of potential infectious diseases. But at this point in time, if there's one reason not to do it, it's called bird flu.
All right, so before we move on to the other viruses, I just want to recap real quick because I think it's important, and both of you are obviously letting us know this. And I'm going to ask you again, how concerned should we be about the bird flu? Dr. Turner?
Yeah, I watch these reports every day because flu shifts quickly. And so as Dr. Del Rio mentioned, not seeing human cases at the moment, but it does not take a lot of a shift for that to start happening.
All right, and Dr. Del Rio?
Same thing as Dr. Turner said. I follow these reports daily. I'm looking at new cases occurring. And what I'm worried about, this is a little bit like seeing water start, getting higher and higher. The level starts going up. And at some point in time, it spills over. So, every day I'm worried a little more as I see more cases occurring in humans. Some of them don't have obvious exposure. But I repeat, my biggest concern, the moment I would sound the alarm, is the moment there's human-to-human transmission. When we start seeing human-to-human transmission, I will be very concerned.
Great information. Thank you, gentlemen. All right, so let's now turn to another type of influenza, and that is more familiar to the U.S., the seasonal flu. Getting a flu vaccine is a great idea for just about everyone, but especially for infants and young children pregnant women and people over 65. So let's kind of drill it down in this graphic. Take a look here. Starting with children 6 months and older. If this is their first ever shot, they will need to get a second dose. People 65 years and older should get the higher dose vaccine, and pregnant women should take the vaccine in their third trimester. Lots of information there. Dr. Turner, there's more than one type of influenza. Can you discuss the differences and highlight which flu strains are included in the yearly vaccine?
Sure. Broadly, we put influenza in two big categories, A and B. A generally tends to be the more severe illness that people have. B tends to be slightly milder. We just mentioned the diversity among those flu viruses and their ability to change, which is why we also have to change our vaccines each year. We try to make those predictions based on the viruses that are circulating typically in the southern hemisphere. Usually what occurs in Australia tends to also occur later in the US in the following season. And so our flu strain this year has 3 different strains that are in it for protection, 2 A strains, H1N1 and an H3N2, and 1 B strain. That's why they call it a trivalent vaccine this year.
All right. And Dr. Del Rio, I was reading here that there's more than one type of flu vaccine, including a nasal spray that uses a live virus. Can you tell us a little bit about that and who should get this, if you don't mind?
Well, there's a vaccine that is the injectable. There's a high dose influenza vaccine used for people over 65. And those vaccines come from kill viruses. And then there's a vaccine that you can give through the nose. It's a live attenuated virus. If you don't like injections, it's a good strategy, but those vaccines are not recommended for immunocompromised individuals. So people who have immunocompromised get the live virus vaccines. Young children should not get the live virus vaccine. So in general, it's a vaccine that has much more limited, I say I would recommend to people get your flu shot. The best thing you can do right now, even if you're concerned about H5N1, is get your flu shot. You may not get immunity against that virus, but you get some degree of immunity. You want to get your immune system at least 20, 30, 40% prepared. It's better than zero. Get your flu shot. That's my recommendation. Do it now, don't wait.
And Dr. Del Rio, the one we were talking about now, the nasal spray, can be taken at home. So you recommend people do that? Should they talk to their doctor? What should they know before using it? Any kind of advice here?
I would talk to my doctor before making that decision. I think, as I said, certain individuals should not get the nasal vaccine. So I would talk to my doctor and receive the appropriate recommendation about which vaccine is best for me. Same thing, if you're over 65, you need to get the high dose vaccine. So really talk to your healthcare professional, and find out which is the vaccine you should receive.
All right, thank you, Doctor. Dr. Turner, I'm going to ask you something that I was told for many, many years. I actually got my flu shot about a month ago. I started in my late 50s, believe it or not, because a lot of people would tell me, if you get the vaccine, it's going to make you sick with the flu. So can we kind of, talk about this just for a few moments?
Yeah, absolutely. So there's a few things to peel away here. I think first off, Dr. Del Rio mentioned that the nasal vaccine is a live weakened version, and we don't give that to immune-compromised hosts. Because in the immune-compromised host, even that weakened virus can cause a weaker form of flu. That really shouldn't happen in normal people with a healthy immune system. For the flu shots themselves, I fully agree with Dr. Del Rio. They're killed. There's nothing alive in it. But I do ask my patients what symptom they had, because I think there is something there to what they're experiencing afterwards. For a simple day after a vaccine, that can be just the effect of your immune system starting to take effect and recognizing that vaccine. If it's something that's achiness, that's actually pretty standard for a number of different vaccinations and is not a true case of illness. The second bit, I certainly have patients where they come into our office, they sit in the waiting room, they're around a bunch of other sick people because it's fall and they spend 15, 20 minutes waiting before they get their shot. And it's worth remembering that the flu shot takes about 2 weeks to give you protection. And so I do believe that there are some individuals who could very realistically catch flu even in our waiting room while they're sitting there ready to get the shot. I even sometimes let them know, hey, if you want to avoid that, go get it at a pharmacy or something where you're not stuck waiting around other sick people if you want to give that a try.
Thank you so much. Before we move on, gentlemen, I want to talk about women who are pregnant. Why are they at greater risk for severe illness? And why is it important, as I'm reading here, that they get a flu vaccine during the 3rd trimester? So would there be a reason why a pregnant woman should not get a flu vaccine? Dr. Turner, I'm just going to give you that one.
Sure, there's not a lot of reasons to avoid it, really limited mostly to a severe allergic reaction or other severe reaction to a past vaccine. It's particularly important in that 3rd trimester because a lot of the mother's body is doing double duty at that point. So the heart is pumping a much higher volume of blood, the lungs are breathing for her as well as baby, and there's a lot of immune system changes. So we know that when women catch influenza while pregnant, the disease is often more severe, more likely to lead to hospitalization. And it goes without saying that that also affects 2 lives now, both the mother and the child. One of the other big benefits, not just in protecting the mother's life, but in giving the flu vaccine right at that 3rd trimester, is some of that immunity also gets baby, who it's important to remember is not eligible for vaccinations until they're at least 6 months old. And so you've got that second benefit on the back end of providing some transferred protection to an infant who could not get the vaccine themselves.
Thank you, Dr. Turner. So today, many people get the flu and COVID vaccines at the same time. So let's look at this graphic that shows the percentage of people who have received flu and COVID-19 vaccines. So far this season, only a little over 40% of adults 18 and older have received a flu vaccine. Adults over 65 have the highest coverage at over 66%. So when it comes to the COVID-19 vaccine, over 21% of adults 18 and older have gotten their shot. Adults over 65 have the highest rate of vaccines at over 44%. So, Dr. Turner, the National Institutes of Health estimates that income disparities and those in underserved communities are more likely to get the COVID vaccine. What are your thoughts on these numbers, if you don't mind?
Yeah, it worries me because I think a lot of the same communities that have perhaps lesser access to health care were also some of the very same communities that had some of the worst outcomes from COVID-19 in the last pandemic. And so it's really unfortunate when you have any risk of a double hit there, both a higher disease rate and then a lower opportunity for protection.
Thank you, Doctor. Dr. Del Rio, health disparities are a real concern in our country. We have the vaccines, but if you don't have insurance, you can't really get them at your neighborhood pharmacy. So what can be done to make sure everyone can get a flu shot, a COVID shot, and other vaccines just to stay healthy?
Well, I think that's a really important point. To me, the vaccines give the ability, in a country with a lot of disparities, vaccines give you the opportunity of what I call immunological equity, equal protection against diseases. And I think we should have for free vaccines against influenza, against COVID, against almost any conditions. It's so much cheaper, so much better to pay for prevention than to pay for cure. You know, age 70 who gets influenza and ends up in the hospital in the ICU, dollars that could have been avoided if you had vaccinated them. Vaccines are incredibly effective as a preventative tool for free in order to create equity.
Thank you, Dr. Del Rio. I have 2 questions from 2 viewers, so I'm going to give one to each of you, if you don't mind, gentlemen. The first one is from Aisha on YouTube. Thank you so much. She writes, back in 2020, COVID had many symptoms, including COVID toes. Are we still seeing similar symptoms, or with the different variants, has this changed? Dr. Turner, would you like to take that one for me?
Sure. Yeah, in general, compared to the 2020 outbreak, the COVID cases have been a bit milder, perhaps a combination of those who have gotten their immunizations, the fact that even those who have not gotten immunizations at least have some past exposure from likely infection. And the more recently circulating strains, in general, do not seem as likely to produce the most severe of disease, like we saw with, say, the Delta wave, for example. In those individuals who still land in the hospital, you do occasionally still see some of those atypical severe presentations, marked inflammatory responses. COVID toes can be a thing that you still see in particularly ill individuals. But by and large, we've been seeing at least lower hospitalization rates compared to early in the pandemic.
And that's good news there. Dr. Del Rio, this one comes from John. It's a comment, and he writes, 5 days into COVID, thought I was getting better. Now I have crazy back pain, impossible to sleep. The pain doubled when I lie down. Oh, I'm so sorry to hear that, John. Dr. Del Rio, your thoughts on this?
Well, again, it's very difficult. I don't like to diagnose people based on just that. This person needs to go see a doctor, needs to find out what's going on. It's unusual to have something like that as a consequence of COVID, but something else could be going on, and checking with your doctor and finding out why you're having those symptoms. That back pain this person is describing is not very typical. It's not what we typically see post-COVID. So I would get checked. I would go see my doctor. I want to really emphasize what Dr. Turner said. Well, we're not seeing the severe COVID that we saw in the past. We're still seeing a fair number of hospitalizations. From October to December to this past week, there have been about 60,000 to 80,000 hospitalizations in our country with severe COVID. The great majority of them have been in individuals over the age of 65, mostly over the age of 80, who had not been recently vaccinated. Again, if you're older than 65, you really need to get your COVID vaccine. It may not prevent you from getting COVID, but it will prevent you from ending up in the hospital or ending up in the ICU, or even worse, dying.
And Dr. Del Rio, Oliver would like us, if you don't mind, to talk about long COVID. Can you take that and just give us your thoughts?
Yes, long COVID is a really interesting post-COVID complication that we're beginning to understand. We really don't know exactly what causes it, but people that get COVID can get a variety of different symptoms after COVID. They could be, brain symptoms like what people call brain fog, just not as normal. It could be respiratory symptoms, chronic cough, bronchial inflammation, repeated infections. There could be cardiac symptoms. You can get inflammation of the heart, what it's called myocarditis. You can get, other diseases. And so really, and you could, fatigue. You can get, just not feeling like doing your usual stuff. And if it goes for longer after COVID, if that health goes beyond what we call long COVID or long-term consequences of COVID. And it's a disease in which the government is spending a fair amount of money trying to understand and trying to, unfortunately, at this point in time, we still don't have good therapies for long COVID. We really don't know what causes it. So the best, when people say, I want to avoid long COVID, the first thing to do is avoid COVID. If you get infected, you got the risk of developing long COVID. So you're worried about long COVID, try not to get infected.
Thank you, sir. Dr. Turner, in years past, we were always hearing about new variants and mutations of the COVID virus. You talked a little bit about that a couple minutes ago. How are they tracked, and are there any new ones we should be concerned about this year?
Yeah, so COVID absolutely continues to evolve or change. Just as we spoke about with flu, we have to update our vaccines from time to time, and at least for right now, we're thinking that roughly annual updates are probably appropriate for keeping us up to speed with the variants that are out there. I will note that because a lot more testing has shifted to home antigen tests, there's a little bit less ability to the sequencing from either research or direct patient testing. In the pandemic, we have switched to using wastewater surveillance for a lot of this tracking now. Most state and local public health departments website where you can take a look at what is circulating locally. By and large, we're seeing subvariants of Omicron. So Omicron has been the continues having subvariants and has stuck around for a while. If you look at a particular strain, KP 3.1.1 generally looks like it's the predominant one in the US. XEC is probably might vary a little bit by locality. I think the good news is Omicron relative variants, they fit well with the vaccine. So I think it's good news for those who have gotten their booster for 2024. The mRNA vaccines contain basically a KP2, which is also in this Omicron family, and so it ought to have. And the Novavax one, although it's slightly different, a JN1 variant, should also do rather well for these ongoing Omicron variants so far.
Thank you, Dr. Turner. At-home COVID tests are an easy way to see if you have the virus if you are feeling ill. But how effective are they against new variants? This next video has some answers. Take a look.
While COVID-19 continues to evolve and produce variants, the good news is that those at-home tests still work for detecting the virus.
The tests we've used over the last 3-4 years don't seem to be significantly impacted by the new variants.
Those tests are looking at multiple parts of the genetic makeup of the COVID virus, so even if there are mutations in one area, the test will still detect the virus.
And then the home antigen tests look for a different protein altogether from where we're seeing these mutations in the recent variants.
So when should you take a COVID test?
I'm recommending that if an individual has symptoms of cough, sore throat, body aches, that they take a COVID at-home antigen test as a first step. If that's positive, you probably have COVID-19 and should stay home for a period of time until your symptoms resolve.
By the way, if you don't have any at-home COVID tests, you can order 4, and they are free. Again, free. Just go to www.covidtests.gov, fill out the form, and you'll get your test by mail. Again, covidtests.gov. Dr. Del Rio, I have a viewer question I'd like to... I'm sorry.
No, go ahead.
Okay, I have a viewer question. Her name is Jill, and she writes this, if you don't mind my sharing with you. I have recently been diagnosed with small cell lymphocytic lymphoma, and I'm hesitant to get a COVID vaccine. Should I be? Dr. Del Rio?
Well, first of all, I'm sorry that you got diagnosed with a lymphoma. The good news is therapies for lymphomas have evolved, have emerged significantly. You have something called a B-cell lymphoma. So your B cells are the cells that produce antibodies. So even if you get the vaccine, you may not likely produce antibodies against the vaccine, against the virus, because your immune system is not in its best circumstance. Having said that, I still think, and I'm not making a recommendation, you need to talk to your doctor, but you can still get the vaccine and give it a try, see if it produces antibodies. But there's a monoclonal antibody that has been approved for people like the antibodies already made as an infusion, and that monoclonal antibody is available for people like you that have a lymphoma, that have immune compromised B cells. So that's another possibility. You can get a pre-made infused that will protect you from the virus. And the most important thing is you want to be protected during the time you're getting chemotherapy, because you're most vulnerable of getting severe disease should you get it.
So, Dr. Del Rio, is there anyone that should not get the COVID vaccine?
Well, if you've had a reaction to the COVID vaccine in the past, but in general, most people do fine getting the vaccine. The challenge with the COVID vaccine is for people for young individuals, as a healthy individual in their 20s and 30s, there's probably not a lot of benefit from getting the vaccine, because those individuals are unlikely to get severe disease, unlike severe complications. So I would say, to get a vaccine, it's okay if you want to get it, but I wouldn't push it. A kid, or if you're an older individual, especially over the age of 65, I strongly encourage you to get the vaccine. Again, I don't want to see you in the hospital. I don't want to see you in the ICU. Prevented that by getting vaccinated.
Thank you. Dr. Turner, I want your thoughts on this as well. And we talked a little bit also about the pregnant women who need to take the flu vaccine during the 3rd trimester. Is it the same for COVID as well? Your thoughts on that as well?
Yeah, I do generally recommend getting vaccinated for COVID during that time as well. We know that there have been good trials, including and specifically enrolling pregnant women. I know in my family, that's exactly how we did it with my 3-year-old who was born during the pandemic, because you've got a lot of benefits. Number one, just like with influenza, women who are pregnant can suffer worse outcomes when they get COVID around that time. And that's a sad thing to see. The second bit is, just like with influenza, there aren't any approved vaccines for kids under 6 months of age. And we do know that a mother getting a COVID vaccine during their 3rd trimester also transfers immunity to the baby during that time. They're a great side benefit.
Thank you, Doctor. Dr. Del Rio, go ahead.
Yes, I would just add, my daughter is currently 33 weeks pregnant, and I have recommended it, and she has received her flu vaccine, her COVID vaccine, and in a couple of weeks, she will also receive her RSV vaccine. Pregnant women really, really benefit, as Dr. Turner said, from getting vaccinated and from having the protection against severe disease, but also the ability to pass that protection to their babies. So I'm recommending to my daughter, and I would recommend it to any other pregnant woman.
Thank you for sharing that, and congratulations to you on becoming a grandfather. Dr. Del Rio, I also have a viewer question, and it concerns a baby. Dottie writes, my daughter's 1-month-old baby had a slight fever, and she rushed him to the hospital. I thought she was being overly concerned. Was she right to go to the ER? Obviously not COVID related, but a great question at that.
You know, if you have doubts, if you start seeing a kid which is having high fever or having trouble breathing, it's better to take him to the hospital and be seen than not to do that. I think you, as parents tend to be very concerned and maybe sometimes overreacting. But I'd rather have a parent that takes a kid to the ER and be seen and say nothing is wrong than wait too long and then having a very sick kid coming to the hospital and potentially ended up really, really sick in the ICU or even die as a result of not being seen. So, access to healthcare, if you have concerns, you should go to healthcare. Olga, let me just add something about the COVID test that you mentioned. In your package, when you get your COVID test, there are 2 tests. And the reason there are 2 tests is because the test may not detect it the first time. If you have symptoms and your test is negative, repeat the test in 24 hours. That's why there are 2 tests in the package, so you can do it twice. But the second thing is they're not free. Unfortunately, they're not free right now. But now we have rapid tests available against COVID, influenza A, and influenza B. And this test that tests you against 3 viruses is really nice because if you can get it, I just had a person I know this past week having symptoms. They tested themselves for COVID. It was negative. Then they tested themselves for one of these tests that had the 3 different tests. And they said, oh, I got influenza A. So the test that, against 3 viruses that you can do at home, if you can afford them, they're very, very good and something that I recommend people try to do if they can get them.
Great information. Thank you so much. Dr. Turner, chime in, please.
Yeah, I apologize. There was one more thing. Just the pediatrician in me wanted to add something for Dottie's question about the 1-month-old. I think one nice thing to remind ourselves about this whole talk is how successful vaccines have been at eliminating some of the previously really lethal bacterial diseases early on in life. And remembering that those kind of 1 to 3 months, the first 1 to 3 months of life, those kids have not yet had the chance to get all of those vaccines. And so that's a particularly vulnerable period. And so I think most pediatricians would certainly agree that a fever in a 1-month-old absolutely ought to be evaluated. And even up to 3 months of age, before even some of those 2-month vaccines have started to take effect, those kids are more vulnerable than just about anybody else. And so I think Dottie absolutely had the right idea simply by the age group.
Great discussion. Thank you so much. All right, so let's move on to the next virus we're exploring today, and that's RSV.
While RSV can hit at any time of the year, winter is when it's most common.
Usually around December, January, we see a huge surge in babies who are hospitalized for RSV infection. Most commonly, they're under the age of 2, but really under the age of 6 months is when they really have a hard time with it.
RSV is a highly contagious respiratory virus that not only affects babies, but also children and adults. However, it's children under 2 and adults who are 65 and older, along with those who have certain medical issues, that are most at risk. In severe cases, RSV can cause trouble breathing and require hospitalization. Experts say you should take precautions and stay home when sick, since the virus spreads easily.
You go out into the world, you're going to have your exposure to RSV. It doesn't have to always be school. It could be the supermarket. It could be a movie theater. It could be a drugstore. There's people out there who have RSV that they don't even know that they're sick. And they can spread it to people who then do get sick.
The CDC recommends pregnant women get a 1-dose vaccine between weeks 32 and 36 of their pregnancy. Infants should either get the RSV vaccine or be given preventive antibodies.
So here are some numbers from the CDC. Each year, the CDC says that RSV leads to over 2 million outpatient cases of the virus. Between 58,000 and 80,000 children under 5 are hospitalized, and between 100,000 and 150,000 adults are hospitalized with RSV. So, Dr. Turner, why are young babies and children so susceptible to this virus?
Children, particularly those youngest ones, have two big issues. One of those is immune system maturation. So their immune system still has a lot of work to do to start to protect against common viruses out there. And the second bit is really small airways. And so this RSV virus tends to injure those ciliated cells that I think one of your earlier videos pointed to. And between all of the mucus production and those injured cilia cells, that leaves a lot of thick secretions that are very hard for those kids to clear from small airways. And that ends up causing a lot more dramatic respiratory distress than your typical virus that affects just the upper airways. Those kids a lot of times end up requiring oxygen or extra support to get through those breathing issues.
And Dr. Del Rio, I guess the same question to you, but about elderly people, why are they at greater risk?
Well, elder individuals in general tend to do worse with respiratory conditions, primarily because their respiratory tract is older. Their cilia don't move as well. They're more susceptible to bacterial and viral infections. And once they get sick, their lungs simply don't have the capacity to respond as rapidly, so they can quickly develop what we call hypoxia. The oxygen drops in their blood, and they will require supplemental oxygen, and they will require, maybe even get intubated and end up in the ICU. The good news is that we have vaccines available to prevent RSV in adults, in pregnant women. So it's really, really important. I mean, I think one of the best things you can do right now, if you're an older individual, is get an RSV vaccine, because Dr. Turner will tell you for young kids who get RSV, we have treatments. For adults, we don't have treatments. So once you get an older individual with RSV, there's not a lot we can do except supportive care, but we could have prevented that hospitalization by vaccinating that individual.
Dr. Del Rio, let me follow up with this. It says here, and I'm reading this, a concern among seniors are serious side effects from the vaccine. So what are the possible side effects and how serious are they?
It's actually a very well tolerated vaccine. When the studies were done, there was a concern maybe of something called Guillain-Barré syndrome. But the reality is, with more follow-up of patients and more, that has really not panned out to be the case. I think it's a very safe vaccine. There are 3 vaccines now available, and it's safe enough that I have been vaccinated, because at my age, I think it's important to get the RSV vaccine. I'm 65, so if I didn't think it was safe, I would.
Dr. Turner, many parents have to send their young children, obviously, to daycare. I would think that could be a hotbed for infection. So my question to you is, what should they do or be aware of to ward off the virus?
Yeah, it sure can. Kids like to share, for better or worse. And a lot of those respiratory viruses survive in secretions, in droplets, on surfaces all over the place. So doorknobs, toys. I had partaken in a study where we actually took glow germ, which is kind of a neat little UV illuminating dye that you can have the kids put their hands in, go have a day in their kindergarten, and then at the end of the day, you blacklight it to see what all they've touched. And it's just about everything except the ceiling. All of those places are places where these respiratory viruses can end up spreading to other kids. I think obviously vaccinating your kids against the conditions that we have vaccines for is the one kind of guarantee that you can do. The best you can do with kids at those early school age groups is at least start to teach the good hand hygiene and cough etiquette. I know they're not going to do it every time. They're still going to have a bunch of nuisance respiratory illnesses throughout the year, but it's about the best that you can do. And honestly, there's not a lot one can do to prevent those kind of early primary kids from having a number of colds or coughs throughout the winter time.
Thank you, doctor. And, as always, there are ads everywhere about the RSV vaccine. It should help people become more familiar with the name. Also, ask your health provider about it so you can be more informed. I want to move on now, gentlemen, if you don't mind, to an illness called Pertussis. Most people recognize this as the whooping cough. It's not a virus, but highly contagious bacterial infection that affects the lungs and airways. Recently, cases have surged in California from over 600 last year to nearly 2,200 this year. So Dr. Turner, can you tell us a little bit about whooping cough and the symptoms and also the dangers?
Yeah, whooping cough gets its name from its pediatric presentation. So when littler kids get this, they can have such severe coughing fits that they end up making this what we call inspiratory whoop, where they're actually struggling to get their air between the coughing, and they make a really unique kind of noise. That can actually cause a respiratory distress and can even make it hard for those younger kids to get whooping cough that will have vomiting spells because of all of the difficulty with the air that they're swallowing, the difficulty with coughing. And so you can imagine, even if it's not the direct respiratory issue, they get dehydrated, their nutrition, and sometimes those kids land in the hospital just to kind of support them through it. By and large, as you get into older ages and adults, you can still absolutely catch it, and it can be probably more of a nuisance, not quite as dangerous as it is to those younger kids, but it's still worth remembering that adults can spread it, and the majority of kids who get pertussis likely got it from a parental caregiver. That's one of the reasons that as a pediatrician, I also recommend to families with a new baby in the household, any caregivers really ought to get updated on their Tdaps to make sure that they can kind of provide that protection against pertussis for the child.
Thank you, Doctor. Dr. Del Rio, there is a vaccine. Did you want to say something, Doctor? My apologies.
Yes, all I would say is, you talk about the vaccine. Before we had a vaccine in 1930s, 1940s, there were thousands of deaths in our country each year as a result of whooping cough. This is a very severe disease in young children. And the reason we're seeing an increase in cases is because vaccination rates in our communities are going down. Again, I recommend to parents, get your kid vaccinated. This is a disease that can kill a kid. You don't want to prevent this vaccine from being given to your children. That is a big mistake. So please get your kids vaccinated. You really don't want to see severe whooping cough. It is a bad disease.
And Dr. Del Rio, I understand there's several vaccines. Can you run through them? There's different types for different ages. Is that correct, sir?
Yeah, there's different vaccines available. Primarily, in general, this vaccine, the DPT, the called DPT vaccine is a combination of vaccines that protects against 3 diseases, protects against diphtheria, protects against pertussis or whooping cough that we talked about, and protects called tetanus. The DPT will be giving a series of injections in children starting at 2 months of age, and then there's you give it at 2, 4, 6 months. You give it then later at maybe at 4 to 6 years. You can give once you get to adults, you use what's called the Tdap. The Tdap vaccine is the one that we tend to use in children, older than 7 adults and adolescents, and this is the vaccine that you then use at the time that either an adolescent, a pregnant individual, or an adult, and it's recommended that usually you get a booster about every 10 years, primarily because of the tetanus component. So that's usually the recommendation, that you stay up to date with your vaccination.
And I hear these, Dr.
And again,
Turner.
I want to emphasize the importance of giving it to pregnant women that we've been talking about.
Right. And Dr. Turner, you're nodding your head. Obviously, these are important. I remember all of these when my kids were small as well.
Yeah, and I do. We obviously focus on the pregnant moms. I think it's also a nice thing for other direct caregivers to those early infants. I often remind them to make sure that they're up to date as well.
Thank you, doctor. Now, pneumonia is another lung infection that can spread in the winter. The common causes of this disease are either a virus or a bacterial infection. Take a look at this graphic. 65 years and older, risk increases with age. Children under 5, a 1-year-old higher risk than a 4-year-old. Weakened immune system, greatest risk. So, Dr. Del Rio, if you don't mind my asking, what are the differences between bacteria and viral infections in pneumonia? And which one would you say is more severe?
Well, pneumonia simply means inflammation of the lungs. It's an infection of the lungs and could be viral, could Pneumonia is simply like saying fever. It's just an inflammation of the lungs, and you need to say pneumonia caused by X. What's the cause of the pneumonia? It could be influenza pneumonia, it could be COVID pneumonia, or it could be pneumonia caused by a bacteria. The bacteria that we are most concerned about as a cause of pneumonia in adults, and for which we have a vaccine, is called pneumococcal pneumonia. There's a vaccine. It's a disease caused by a bacteria called Streptococcus pneumonia. And against that bacteria, we have a vaccine that we can give. Again, we've been emphasizing individuals over the age of 65. Individuals over the age of 65 can get vaccinated, even over the age of 60, can get vaccinated against pneumococcal disease and be protected. The pneumococci, like other bacteria, or like when we think about flu, has multiple serotypes. And the current vaccine covers multiple of those serotypes. There's a vaccine available against 21 serotypes. So you get the most updated vaccine. You can vaccinate children, you can vaccinate young adults, but for individuals over the age of 65, there's a pneumococcal polysaccharide vaccine that we can give. And as I said, I really strongly recommend people who have underlying lung disease, people who have heart disease, people who have diabetes, people who have kidney disease, and anybody over the age of 60, 65 to get vaccinated against pneumococcal disease.
And Dr. Turner, what's the relationship between pneumonia and COVID-19? And a follow-up question I have is, are there other diseases that could lead to pneumonia?
Yeah, absolutely. So COVID does interfere with the immune system. It's one of the reasons that people get reinfections often. When you're talking specifically about pneumonia, it varies depending on how severe your COVID was. I think it was a University of Michigan study that suggested that about 3.5% of people who get COVID end up with a bacterial pneumonia, either along with it or shortly thereafter. It's a very different story for people who are severely ill and land in the hospital, because they become prone to all kinds of other types of pneumonias, honestly, in part because of some of the extreme support measures people need for severe COVID. So for those who have the dramatic inflammatory response, they might end up getting a course of steroids or immunomodulatory treatments to help them out. And those can make them more vulnerable to unusual infections. We've seen increases in incidence of fungal pneumonias and other infections for that population. Additionally, the individuals who become ill enough to require a ventilator or intubation during their hospitalization, they're at markedly increased risk for pneumonia because of having a tube in their airway that ought not normally be there. And those individuals end up getting what we call hospital-acquired or ventilator-associated pneumonias. So yeah, there's unfortunately a lot of ways that COVID can lead to other adverse infections.
Thank you so much. I want to move on now to outbreaks of Mpox in Africa and just recently in Germany, where 2 school-aged children were found to be infected. Mpox is in the same viral family as smallpox. It can be spread by close contact with infected people. There's no specific treatment for this virus. So Dr. Del Rio, there are 2 types of Mpox. Can you explain what they are and the difference between them, please?
Well, currently when we worry about Mpox, as you say, 2 clades. There's Mpox clade, 1 and clade 2. The one that we saw circulate in if you recall, a couple years, we saw a lot of cases of Mpox clade 2 around the world, really, primarily affecting men who have sex with men. In Africa, we see a lot of Mpox, and the clade 1 is the one that tends to have more severe disease. It's in many Central African countries and been seen in other parts of the world. So a case of Mpox clade 1 was detected earlier here in the United States. So we're monitoring this very closely. The drugs that we have, we thought we had a drug called Tecovir, not proved to be effective against Mpox. So again, there's a lot of research that needs to happen. We do have vaccines, and the vaccine has efficacy. High risk of Mpox clade 2, a man had sex with man, get vaccinated. And there's a lot of efforts globally to get vaccines to countries that have Mpox clade 1, because the best thing we can do is really to stop the outbreak from continuing.
Thank you, Dr. Del Rio. We've only got a couple minutes left, and I just don't want to end the show without talking about shingles. So let's talk about that real quick. About 1 million people get shingles each year. People get shingles when the virus that caused their chickenpox reactivates. It produces a painful rash that appears on only one side of the body. So, Dr. Turner, let me go to you. Your thoughts on shingles, getting the vaccine. I'm going to be honest, since Dr. Del Rio disclosed his age a little earlier in the show, I'm 57 and I've never gotten it.
Yeah, we generally recommend it for individuals over the age of 50 who have had chickenpox earlier in life. And I think any one of us who has taken shingles or knows someone with shingles has a personal motivation to get it, because shingles is a really painful, unpleasant condition. It's not quite as simple as just a simple localized rash that goes away quickly. A lot of individuals can suffer pain along the area where the rash was for months afterwards. Even some individuals can have neuropathic pain that becomes essentially permanent after that infection. And so anything we can do to prevent that reactivation seems really nice for quality of life. And there's a very effective vaccine for it, 2 doses. I always warn people that you can feel a little bit achy after that dose number 2. That's normal. It's because your immune system has been primed for it. But that is a short-term pain to prevent a long-term pain.
Dr. Del Rio, I've got about 10 seconds for your thoughts on shingles.
I would say get the vaccine. The current is incredibly effective. I'm vaccinated myself. My only recommendation to people is I call it a Friday vaccine, because if you feel sick, you want to have that Saturday to recover. It's a vaccine that has significant side effects. You're going to get a very achy.
Thank you.
So maybe that day off the day after you take it. So it's a Good Friday vaccine. But it's worth all the pain you get, because you don't want to get shingles.
Thank you. And thank you for your time. Take care.
Thank you to the Eunice Joyce Gardiner Charitable Foundation for its leadership support of the Health Channel.